I like to start with just putting the food in front of the patient, just saying, can you just eat some of this for me? So not giving them directions, not starting out with like, you know how we tend to start out with, let's do a teaspoon, then a cup sip, then a straw sip, and we move through all these different bolus trials. And of course you should still do that because you want to see like, oh, if this person is coughing or having overt signs or symptoms of aspiration, you want to collect some information about like, does bolus size or the flow, is that impacting these symptoms? But you also want to do a really thorough assessment of eating. And so by just freely giving them food, you can kind of get an idea of what their feeding habits look like.
So where does this research come in?
Dysphagia Research Bites.
Welcome to the Dysphagia Research Bites podcast, which is a podcast designed to make dysphagia research more clinically digestible for speeches, especially those working in home and community-based settings. My name's Chantelle, I'm a speech pathologist, and I started this podcast because dysphagia care doesn't just happen in hospitals. It happens around kitchen tables, in aged care facilities, and in everyday life. Community dysphagia work is complex, it's nuanced, and it's often underrepresented in conversations about swallowing. So, if you're looking for clinical tips and thoughtful, evidence-informed conversations that actually translate to practice, you're in the right place. Today, I'm speaking with Jackie Rodriguez. Jackie has been working as an SLP since 2016 across a number of settings, including inpatient rehab, outpatient, acute, skilled nursing facilities, schools, and private practice, just to name a few. Jackie is bilingual and is passionate about topics including dementia care, bilingualism, ableism, and social justice. Jackie also enjoys lecturing at conferences and universities and has created a comprehensive resource for SLPs on dementia, which is available on Teachers Pay Teachers. All right, so we have Jackie Rodriguez today, and I just want to say that, Jackie, thank you so much for being here. I first discovered you through Instagram, through your page. Now tell us, what's your handle?
It's at unlearnwithme.theslp.
Yes, excellent. I absolutely love your posts. You're talking about a lot of stuff. It's not just about dysphagia. I can see you're really passionate about dementia. You're passionate about bilingualism and other social issues as well. And I just really love keeping up with your posts and your stories. So that is how I found you. And I feel really lucky that you agreed to be on.
Yes, I'm glad to be here today talking to you.
Can you tell me how you came up with your name, Unlearn with me? Yes, I love that name, by the way. How did you come up with that?
So originally my page was actually just like my personal Instagram. And it started out as every Black History Month and every Hispanic Heritage Month, I would do these like really elaborate stories on different topics, because those are my two personal backgrounds. My mom is African American and my dad is Puerto Rican American. And my page was a private page at the time. And people kept saying, like, this is so good. Like, you need to make your posts, you need to make your page public, and so more people could see this. And then I took the suggestion, and I started like connecting my job as a speech language pathologist in with history and talking about like social justice as it relates to speech language pathology. And then I started being asked to present at all these different conferences. And it was kind of like, okay, my handle, I literally made it when I was in college, and it was AJAC A. And I was like, this is embarrassing that I'm being introduced at these like talks and my page is still AJAC A. And so I asked my followers, because I was like you mentioned earlier, my page is not really about one particular thing. I talk about a lot of different issues. And someone was like, well, I'm always like just unlearning things with you. So why don't you make your page Unlearn with me? And so I try to be as objective as possible when I talk about different social issues, like either as they relate to speech pathology or as they do not. And I try to talk about, things and talk about the nuance and the gray area, because I think culturally we are so polarized in everything that everything's either you're on this side or that side, or you're right
Mm-hmm.
and wrong. But it's okay to like be in the gray area. And so, Unlearn with me, I just encourage other people to like unlearn biases that they have about different topics.
That's great. It's so fitting for your page. I'm definitely unlearning a lot by following along with you. Thanks, Jackie.
Thank you.
Jackie, why did you choose this particular article? So I reached out to guests and I asked them to pick an article that, they love or has changed their practice or maybe they just find interesting. But what was the reason you chose this particular article?
So I chose this article. So dementia is like an area of passion for me.
Hmm.
So a little bit of backstory about how I got into this field. So my mom had rheumatoid arthritis, and so growing up, she had 3 inpatient rehab stays. So I kind of felt like I always was going to therapy with her. And then my grandfather passed away of dementia 3 years ago. Um, and so I started in this field in the schools. And then during the pandemic, I transitioned to being a travel speech pathologist where I was working short-term assignments in different places. And I was mostly working in skilled nursing. So it was like a wonderful time to transfer when, we're on lockdown and
Hmm.
these like skilled nursing facilities in the United States were having these massive outbreaks. So that was sarcasm. It was a very stressful time to make that transition, and that was around the same time that my grandfather was diagnosed with dementia. And so I felt like, if I can't go and visit with him, I can be with these families that are these patients with dementia who are so like isolated from their families. And so it just really became like an area of passion for me. And then, like, the more that I started learning about dementia, the more I realized that, like, speech language pathologists really have, like, a very limited knowledge about dementia.
Hmm.
I think that everyone, well, I don't want to say everyone, but I think that a lot of speech pathologists kind of treat dementia like as if all of their patients are hospice care and like there's not a lot we can do, and there is a lot, but our treatment for people living with dysphagia, I mean living with dementia, is going to look very different to someone who has had a stroke or who's had head and neck cancer. So that's kind of how, this passion has built. And then I've had experience working in a variety of settings. So I worked in SNFs as a traveler. And then when I came back permanently to Atlanta, Georgia, instead of taking a full-time job, I work full-time PRN, meaning that instead of having one full-time job, I have multiple PRN jobs.
Hmm.
And so I've kind of bounced around in different settings, but I've gotten some acute care experience, and now I'm primarily between inpatient rehab and outpatient. So I've really seen how
Mm.
what dementia looks like in all these different levels of care and how
Yeah,
we need to kind of change our practice depending on the different level of care that we're working with our patients in. So.
amazing. Okay, so the article we'll be talking about today is called Dysphagia in Persons with Dementia, the Dual Diagnosis Challenge. So this was written by Michelle Tristani and published in Perspectives of the ASHA Special Interest Groups in 2016. So, this paper talks about swallowing difficulties in people with dementia. Tristani explains that both swallowing and cognition are deeply tied to quality of life, and that managing dysphagia in this population means constantly balancing safety with dignity and pleasure. She points out that there are still no standardized guidelines for this dual diagnosis, and clinicians must rely on careful reasoning to tailor management. And it's estimated that anywhere between 13 and 57% of people with dementia also experience dysphagia. The paper highlights how neurodegenerative changes affect not just memory, but also attention, sensory awareness, and motor control, all of which influence mealtime behavior. Tristani reviews existing assessment tools, discusses the value of environmental and sensory approaches, and emphasizes that changes in eating are not simply a matter of forgetting how to eat. So, firstly, great article that you chose, Jackie. I loved it. So many practical tips for how we assess eating and drinking, intervention techniques, how to address particular areas of impairment. Just banger of an article.
It was definitely like a pivotal article for me to really understand how dysphagia presents in people with dementia.
Yes. And I find that with research articles, sometimes it's, you read the article and you're like, oh, that's really interesting, but what can I do now? How do I use that information? This was not one of those articles.
No, no. Yeah, it's very practical and
Yep.
easy to refer back to because sometimes you'll have those like highly technical articles where it's like you got some good information, but then you need to read the whole article over again to like remember this one little small piece of information. Whereas the way that
Yes.
this is divided, it's super easy to go back and like review one quick section if there was something that you couldn't remember from it.
Yeah, absolutely. All right, let's talk a little bit more about the article. There was a term in there. There's a couple of terms actually. Firstly, cognitive-based dysphagia. So I haven't heard this particular term before, but I wanted to talk about this for a second because it's one of those things that I've thought about a lot. So when people say dysphagia, are they only talking about the physiological impairment? And it made me also think of our clients with, say, intellectual disabilities. We might have other terms like feeding and swallowing disorder, because it may not be necessarily about the physiological impairment, but I'm not actually sure how frequently that term's used in practice, with adults anyway. So that term, do you use that term? Is that something you've come across before? Can you give me your thoughts on that?
Yeah, so I do see that term a lot. And I'm curious to know like if it's a country cultural difference too.
Mm-hmm.
Because you do see that a lot here in the States. You'll see like cognitively mediated dysphagia. But
Ah,
even I've noticed like in some of the settings that I worked in, it also seems to be like dependent on the culture of wherever I'm working. So like some places
yep.
will just be like dysphagia and then describe how like cognition is playing a role, whereas other facilities that I've worked in, they've used the actual term cognitively mediated dysphagia. And
Mm,
yeah, it's hard to determine like it's not easy for our patients with dementia to tease apart like how much of it is cognition and how much of it is dysphagia. And another thing that I see a lot too is people will say, well, I have a patient who has dementia, and let's say they're in the like middle stages where a lot of times those patients have trouble with attention and they have trouble
hmm
with sitting at a table to attend to a meal. And so these patients are at really, really high risk of weight loss,
hmm
and muscle wasting. Just one because of the the disease process, but then also because they're not eating enough because they're not attending to their meals. And so I'll have people say, well, technically there isn't like an oral dysphagia or a pharyngeal dysphagia happening, that this swallowing problem is truly related to cognition. So like, how should I bill for it? And I think
mm,
you could make a case for billing for both because you are work because a lot of times what you will see sometimes is like maybe in your initial assessment you don't see any like oral or pharyngeal issues, but then when you are able to get that patient to sit down, or if you do like some sort of a handheld type snack that the person can be on the go with, then you start realizing, oh, they're also not attending to the bolus in their mouth. So whenever I have a patient who it's kind of like a toss up about whether it's cognition or truly like a physiological deficit, I just go
hmm
ahead and add both billing codes to my eval.
hmm
And then you've kind of, because at the end of the day, it is impacting both. So,
Yep. That's something I hear that I think that's something that's very different between our countries as well. So I do hear
hmm
you guys talk a lot about billing codes.
hmm
Here, I think we're a bit lucky. I think it's a bit more straightforward. We don't need to be differentiating things like that, and it all is
Uh-huh.
sort of billed the same sort of way. The other thing that the article said as well, which I really liked, is it just mentioned that dysphagia, so we're talking about the physiological impairment-based dysphagia, I'm guessing, usually appears in the moderate to severe stages of dementia.
hmm
And I thought that's important for us to keep in mind because I think what happens a lot of the time, and I'd be interested in your thoughts, is speeches will just hear that someone has dementia. And then I think sometimes we're already sort of stereotyping and maybe providing our intervention in a biased way, or we're going straight to compensation or straight to management. What do you think about that?
Oh my gosh, absolutely. That is something that really drives me crazy, and that
Mm.
is something that has really fueled my passion for educating speech pathologists about people with dementia. Because even I've been able to I have a patient on my caseload right now, an outpatient who has advanced dementia, and I'm able to get him to do pharyngeal strengthening exercises. And
Wow.
the way that I instruct him in doing that is very different than a patient who's had a stroke or a patient who does not have cognitive impairment, but I'm able to get him to do that. So I think that yeah, we're definitely very quick, and there's ableism to that about
Mm.
what we think a person with dementia can or cannot do. And I think, like in the article, how she talks about when we are working with a patient with dementia, it is important that we've done both a cognitive assessment and a feeding assessment and a swallowing assessment to be
Mm.
able to give the best input about how we could support these patients. Because if you're just assuming based on what you think this person is able to do, then you're gonna miss a lot of good information about things that this patient actually might be able to do, strategies that they might be able to engage in.
I liked how it talks about the role of sensation in terms of the motor aspect as well. So I think when we talk about sensation as therapists, often we think, oh, that means they might have some, residue left on their tongue, for example. But I don't think we're necessarily thinking about it in terms of its impact on the motor part of swallowing. And I know that it's not 100% clear exactly how it affects
Mhm.
that, but I think we know that it does. But I thought that was a good reminder.
Yeah, for sure. And I think that speech language pathologists to see patients in long-term care, that's a constant issue that's brought up.
Hmm.
And it's very intimidating where you give a patient food and they're holding it in their mouth, and you're like, oh no, I don't know what to do. This patient isn't following commands. I can't get them to swallow. They won't open their mouth. So yeah, we don't talk enough about that suspected oral apraxia that happens as the dementia progresses. And I would love to spend some time talking about strategies for that more like late advanced dementia and what you can do to support those patients. Hmm.
There's also a great table outlining the progressive impact of dementia on swallowing, and that's broken up into early stage, middle stage, and late stage. That's great,
Hmm.
quick reference table. And then there's also a great diagram as well showing a clinical pathway for swallowing in people with middle and late stage dementia. So it lists
Hmm.
like the different assessments to use for the clinical swallow eval, mentions how to assess cognition, breaks it down to list specific cognitive symptoms versus specific physiological symptoms. There's just lots of really cool little resources within the article itself.
Yes, it has so much great information for sure.
All right, so Jackie, I want to know, do you have some specific tools or specific approaches that you tend to use fairly regularly when you're assessing dysphagia in someone with dementia?
Yes. So I know it talks about some of the standardized assessments that have been created for people with dementia,
Hmm.
like the dementia mealtime assessment tool,
Yeah.
the ECAT. Unfortunately, I don't have access to a lot. Like the ECAT is an actual like assessment that you have to purchase. I
Yeah, that's
believe
quite
I have
expensive
the
too, isn't it?
it is, yeah. I
Yeah.
think I have the DMAT, but I was like reading through the pieces of the ECAT to see like what information is on there.
Yep.
And part of what I did as I was like learning about dementia and how I could educate other speech pathologists, I created an ebook that I have in my Teachers Pay Teachers store. And I created like an informal checklist with some things that I look at with my patients with dementia. And I will say that depending on what setting I'm seeing these patients in is going to look very different, right? And I think
Yeah.
ideally, your long-term care patients, they have the biggest advantage when it comes to assessing feeding with people with dementia because they can see the patients in the actual environment that they're in.
Yeah.
They could be in the dining hall. They could be amongst all the chaos, all the distraction to really see what's happening. Whereas when you see someone an outpatient, when you see someone an inpatient, even when you're doing a modified barium swallow study, that is such a like sanitary, like perfectly calming environment.
Yeah.
So, some things that I like to do, especially when you don't have access to what the person's natural eating environment is going to look like, is I like to start with just putting the food in front of the patient, just saying, "Can you just eat some of this for me?" So, not giving them directions, not
Hmm.
starting out with like, you know how we tend to start out with, let's do a teaspoon, then a cup sip, then a straw sip, and we move through
Mm.
all these different bolus trials. And of course, you should still do that because you want to see, like, oh, if this person is coughing or having overt signs or symptoms of aspiration, you want to try to collect some information about, like, does bolus size or the flow, is that impacting these symptoms? But you also want to do a really thorough assessment of eating. And so by just freely giving them food, you could kind of get an idea of what their feeding habits look like. Some other things you can do too is so when we're concerned that there could be potentially some like cognitive factors that are at play, if you're working in an office, open your door so that there's distraction
Mm.
outside of the office. If you've
Yeah.
got a patient who, especially a male patient, like I don't want to sound sexist or anything, but you get a lot of times we get our male patients who come with their wives, and their wives are super sweet but so chatty, and they are just running your mouth the whole time. Let that wife keep talking because I guarantee she's also going to be talking to her husband at meal times like that, and
True.
that's going to give you some good information too about, like, is this patient having trouble with coughing because everybody's talking to him and he's having trouble with that divided attention of like engaging in a conversation and also eating during a meal time. So those are
Yes.
going to be some things that I look at. You also, if you have access to the patient's like chart. So, like here in the United States, a very common EMR system is called Epic.
Hmm.
And a lot of like private primary care physicians use that as well as like the hospital. So that can be a benefit because you can look and see like if the patient has been to a neurologist or if the patient has been to a neuropsychologist, you could see what their testing shows
Hmm.
to kind of get an idea of what the patient's level of cognitive impairment is like. Or even if, I don't know if it's the same in Australia, but a lot of times, like our primary care physicians will do a screener. Like they might do the slums or the mini mental test.
Oh,
And
yeah.
although it's not like a thorough cognitive assessment, if the doctor has done it and the patient scores a 10, which like I think an average score is like 24 out of 30, then that's
Mm-hmm.
going to tell you that that patient has pretty significant cognitive impairment, right?
Yep.
So, and that's something you could do even if you're in acute care. Another thing that I'll do too is I'll ask the family members, like if the person like actually has a formal diagnosis of dementia, I'll say, has anyone told you like what stage of dementia your family member is in? And
Mm-hmm.
so like I have a patient right now that I'm seeing in inpatient rehab, and it's been kind of hard to figure out like this patient he had a fall and a brain injury. And so, when you get a person with dementia, baseline dementia that's had a brain injury, it's hard to kind of tease apart like what is baseline cognitive impairment versus what is new impairment. And so
Yep.
this patient's spouse told me, well, he was diagnosed with moderate Alzheimer's dementia. So that there kind of gives me some good information as well. So we have to kind of be a detective because I know that like oftentimes when we see these patients, we've only got, maybe 45 minutes to an hour to do all of this assessment, right? And then
Mm-hmm.
from there, don't feel like you have to do all of your assessment in one single treat. It might be that like, well, today I'm gonna have this person come in and I'm gonna do like a more standard clinical swallow evaluation where I do a cranial nerve assessment, I do some trials. Then next time, like I don't know if I have enough information to know cognitively what this patient can do. So I am
Mm-hmm.
gonna do on my next assessment a full cognitive battery.
Mm-hmm.
And then I might even try to replicate like feeding as well. So kind of like what I mentioned earlier, where you try to set up as close to as possible some sort of a meal so that you
Mm-hmm.
can get an idea of what this person's feeding behaviors are like.
Right. Now, you mentioned that you might do a full cognitive battery. I wanted to ask you a little bit more about that. What are some of the batteries that you might use over there if you're doing that assessment?
Yeah, so it kind of depends on where the patient's at. If they're in the earlier stages of dementia, I might do something like the CLQT,
Oh, yeah.
the cognitive linguistic quick test,
Mm-hmm.
and do that complete battery.
Yep.
If they are more advanced and I don't think that they could tolerate a whole battery, I might do a screener, so something like
Yep.
the slums or the mocha, and
Oh,
then
yeah.
I'll supplement with a dementia rating scale. So you have things like the global deterioration scale, the GDS, and then the GDS pairs with the brief cognitive rating scale. And so that asks questions about like, is the person able to like dress themselves at home? Are they oriented to like things that have happened over the weekend or over the past couple of days? So even like if you can do testing that could help you to stage the dementia, that's really
Mm-hmm.
like as we move into the more like moderate and severe stages, you want to staging is going to be more important than like a cognitive than like doing a complete test because they might not be able to tolerate a full battery like the cognitive linguistic quick test, but
Mm-hmm.
and then they're also not going to like improve. So at the end of the day, like I think what I'm looking at the most as it relates to swallowing is going to be memory, particularly to
Mm-hmm.
see if they are going to be able to recall the strategies.
Yep.
And then also attention. So it doesn't always have to be like a full standardized test. You can do screeners
Yep.
and then add in like informal type things as well.
So that was part one of my conversation with Jackie. Tune in next time for part two, where we'll talk about things like enteral feeding, oral apraxia, and our role when it comes to decision making. Thanks for tuning in to the Dysphagia Research Bites podcast. If you want more dysphagia education, then head over to Instagram at Dysphagia Community or www.dysphagiabites.com. Bye-bye.
Bites.
I stuffed up my chopsticks.
One thing that you had to